Welcome back to another episode of the Movement Revisionist Podcast. I have a familiar face here, obviously Nicole Lorenz. We're going to dive into some pelvic floor concepts, especially when to Kegel and when not to Kegel. That is the question. And we got pelvic floor models, so let's just dive right in. Since many of people already know who you are, you can kind of reiterate who you are, what you do, and your practice.
All right. Dr. Nicole Lorenz, physical therapist. I specialize in orthopedic and pelvic floor physical therapy here in Plymouth, neighbors with Dr. Mitch.
Yep.
And so the topic today, to Kegel or not to Kegel?
That is the question. Dun, dun, dun.
It's a big question. It's something that's hotly debated right now in social media. And of course, social media gives you snippets of like, oh, don't Kegel. Oh, but you should Kegel. And then you've got, docs handing out pamphlets that you should definitely Kegel. And everyone is kind of just left without a lot of...
Yeah, everything's kind of thrown up in the air. So let's be smart. I like to think we're somewhat smart. Let's start with setting the foundation. What the heck is a Kegel? I'm guessing it's someone's last name.
It was. It's somebody's last name. Ironically, it's a male.
Oh,
male physician.
I wouldn't have guessed.
Came up with the Kegel. And so a Kegel is a volitional engagement of all the pelvic floor, basically. It's hard to isolate one muscle group versus another. So the whole pelvic floor engages volitionally without a corresponding increase in intra-abdominal pressure is the goal.
Oh, interesting.
The idea of a Kegel.
Yeah. Now, that's primarily just a concentric contraction,
that's just the
right?
concentric contraction is engaging pelvic floor.
Yeah, and I think everybody listening has probably tried a Kegel or trying to get that feeling, because guys have pelvic floors too, if you didn't know.
It does turn out they do.
So everybody can try a Kegel, but I think it's just like with any rehab or exercise or stretch, there's not really bad ones, but it's about the implementation and when that person should do it. So
correct.
Go ahead.
And so there are bad ones, turns out. There have been some studies done on whether or not patients are correctly performing a Kegel. Some different, research methods there, but using some sort of like a force pressure device. And so patients sometimes, whether they have maybe seen their OB or a physician, are given a pamphlet on how to do a Kegel, kind of instructed to, just stop the flow of urine.
Yeah.
And studies have shown that I think it's something like 50% of patients, when they're just given either verbal or written description, aren't quite getting it right. Either they're over-engaging glutes, hip external rotators, like hip musculature, or they're valsalvating, and they're increasing intra-abdominal pressure. So
Gotcha.
Kegels can have their place, but we will also want Kegels to be done properly without overactivity of the glutes or without that Valsalva increasing intra-abdominal pressure, especially since a lot of the time that we're doing Kegels, we're trying to maintain continence and not increase intra-abdominal pressure.
Yeah, which makes sense. And it's weird. That seems to me, knowing a lot about human movement, trying to do a Kegel seems like a very advanced volitional movement. I could barely get someone to squat, and you can see a representation of what a squat looks like.
Yeah, I think that's the hard part, is that it's not something that you can visually see. If you're doing it right, you're really not experiencing any kind of skeletal movement. A bicep curl, super easy. You've got a lot of visual cues there.
Yep.
To know that you're doing
Before,
it properly.
After, you can kind of see.
Yeah, so it's harder to know that you've done it properly. And that's kind of where pelvic floor PT comes in. In the case that it's necessary that patients are comfortable, we have the ability to kind of cue them as to whether or not they're performing a Kegel properly, if we feel it's necessary in their case.
Would that be more through like palpation or hands-on?
Yeah, through hands-on manner, like, you're internally palpating for volitional engagement of the pelvic floor. And then you can give them direct feedback as to, if they're engaging well, or if maybe it was more accessory muscle, or if what they did was more of a Valsalva and they've increased intra-abdominal pressure.
Yeah.
And there are also like electronic devices, biofeedback devices that can be utilized for patients to monitor this like in clinic or at home, you know, to self-assess or to self-check for like home programs.
Technology
is pretty awesome.
It's helping.
There's actually one that I know of on the market made by like a women's perinatal product company. And it connects via Bluetooth to your phone, so you can have a visual representation on the screen of your phone if you are getting the
how
correct
powerful that contraction
muscle
is.
engagement. Yes.
Wow, super cool. Well, and I figured you were going to talk about most people are just not doing them correctly, which is common with any exercise, yet alone Kegels. But also, is there a certain time we should be doing Kegels? And then maybe we'll dive into maybe when we shouldn't and we should be looking at other things.
Yeah.
Because the pelvic floor isn't just one function. It doesn't mean, which if it doesn't have one function, then one exercise isn't going to fix it.
No. Yep. Kegels I find are great when a patient comes in and the pelvic floor is, you know, truly weak. Like you've done a manual muscle test and it's weak, but you can tell maybe that they're engaging well and that there isn't secondary tightness within the pelvic floor or trigger points.
Can I a nerd question?
Yeah.
Where do you feel usual trigger points?
Trigger points can be felt throughout any of the layers of pelvic floor musculature. And then it depends on each person's case where they're experiencing some of that muscular restriction.
Yep. Like a certain dysfunction, is there usually a certain trigger point associated? Or is it you're just kind of collecting data?
Yeah, it's more like collecting data.
We're always trying to find shortcuts in clinical practice, so I was just curious.
Yeah, it's kind of more of assessing, you know, getting that whole, you know, subjective report from a patient of what they're experiencing.
Yep.
Collecting your data points, strength, and again, pelvic floor evaluation is just one more data point. Sometimes we don't even need it, but it's often a great data point to have in treatment. So yeah, you're kind of assessing all the way around the pelvic floor if things are engaging well, not engaging well, if it seems maybe like it's a strength and connectivity issue, because sometimes for people it's just getting that mind-body, brain-body connection, getting those neuromuscular patterns to fire, where maybe the muscle isn't entirely weak, but they're not connected to it very well, and it's just kind of firing.
They just have no experience with trying to actually use their pelvic floor outside, well, volitionally. Hopefully everything's working involuntarily wise.
So in those cases, if somebody's not really cued in well, we'll cue pelvic floor activations or Kegels as maybe just a few reps or sets as just a way to kind of reconnect brain to body there. Or I recommend them in cases where the pelvic floor isn't strong enough to meet the demands of a task.
Makes sense. Like, is that like a clear, like incontinence, like, hey, I'm at the gym and I'm dealing with like leakage? Would that be an example?
Sometimes, but sometimes leakage with, you know, strength training or exercise activities can be that the pelvic floor is too tight and it's not providing the amount of force closure to the urethra, and then you're adding some sort of exercise and increasing intra-abdominal pressure, and now you have
when
this
you're
offset.
In a concentric state. So that was a high-level plant because I knew that would get us into the next talk. I'm trying to get better at podcasting, if you're wondering. That was a good tee up to maybe when too much concentric activity could actually be causing your symptoms. You kind of touched on it a little bit, but what are some common things people might see just from like a self-assessment? Hey, this happens to me. Maybe I shouldn't be doing Kegels on my own all the time. Obviously, the number one answer is if you got something going on and you don't know how to fix it, there's people out there. We're spreading the good word, is what I'm getting at.
So the concept of like when not to Kegel, right?
Yep.
I would say Kegeling becomes a problem, or more muscle activation becomes a problem when a muscle is already too tight, for lack of a better word, or you've got too much muscle activity and you need to get the muscle to have, or your goal is that the muscle would be more relaxed. There may still be cases.
Yes.
Gray area for using a Kegel there, but Yeah, typically maybe if somebody's experiencing more pain, or we're working with a pelvic floor evaluation and finding greater amounts of tightness within the pelvic floor, Kegels may be something I recommend later in therapy, but first we're going to try and like downtrain or downregulate the pelvic floor tension, so that then when we add back in a Kegel or an intentional pelvic floor activation, they've got more of a full range or full excursion of that muscle.
Yeah, and that plays into the different functions of the pelvic floor, which we touched on in the structure and function mini episode that you should check out if you haven't watched it yet. Shameless plug there, where obviously we know muscles contract, but they also have to relax or just eccentrically contract. So I'm sure the pelvic floor, I use it as an example of like core stability, where everybody's told to, suck in. It's like, well, if you're taking a muscle from mid-range and constantly just going from mid-range to full concentric contraction and not allowing for the ability to get through the full range of the muscles and its function, you're probably not going to be as strong overall, right? I would imagine it's probably a similar thing for the pelvic floor.
It's exactly the same.
So what are some things that need to happen? Because most people think they need to tighten things up down there, which again, in-person assessment with a professional would kind of diagnose your issue. Because I'm sure there's cases where you have a little bit of both. Maybe they need this at the beginning, but then we're going to transition towards the other half, or you know how clinical practice is. You never know.
Most people are not just one extreme or the other.
It's gray.
It's definitely a gray area.
Black and whites do happen. It's like, yeah,
fun.
this is,
fun.
I'm like, finally, something easy. But it's never really like that.
Yeah. So, yeah, you need the pelvic floor to be able to kind of go through that full concentric to eccentric or elongation range. Otherwise, you're not going to be as compliant or responsive to, your environmental changes in the cases of like stress urinary incontinence. So yeah, I will often, if I find that the pelvic floor is too tight, not recommend a Kegel or a pelvic floor activation initially, and have maybe our first couple of sessions focus on relaxation, breathing.
I was going to say, I knew it was coming.
Sometimes it's stretching of hip external rotators, posterior pelvic floor, maybe sometimes giving patients actual homework to work on soft tissue mobilization of the pelvic floor.
Now I'm guessing, just because I don't work with the pelvic floor, but are you sending them home with manual kind of muscle techniques and then immediately doing breathing afterwards?
Yeah, in and
or
around
during? So what are some key things, because I already know, and we can nerd out with it. Why is the breath so important in our breathing function and so important when it comes to pelvic floor function?
So our respiratory diaphragm and our pelvic floor work in sync.
I'm getting better at my editing skills, so I'll try to put like a diagram right in between us.
Yeah.
We'll see. If it's not there, I apologize.
So as we've talked about, that pop can model or a piston model, when patients are just taking shallow or like shorter upper chest kind of breath mechanics, that diaphragm isn't getting its full excursion, and so we're not working on maintaining intra-abdominal pressure very well. So one of the first things I dive into with patients is like, how well are we breathing? And are we getting enough diaphragm excursion? Because you're supposed to get diaphragm to descend, pelvic floor to descend nicely, and so that we're maintaining that pressure there.
Yep, and alignment plays a big role as far as rib cage over pelvis.
Yeah, rib cage over pelvis. If not, you're gonna be working a lot more hard. You're working harder, less mechanical advantage. Advantage. And then as we exhale and diaphragmless, pelvic floor should also somewhat engage.
Especially during an activity, so we're at least keeping a baseline intra-abdominal pressure to stabilize.
Yeah, and so that's where...
For you nerds out there.
So that's often where I will start if we're looking for like pelvic floor regulation. They get real in the weeds with it. Some of my favorites are like being in like a child's pose position where you're just in a lot of lumbar flexion, and then having the patient work on that nice three-dimensional diaphragmatic breath, because then it kind of forces them to get excursion through like the backside of the rib cage and diaphragm, and then in that posture, it also correlates to like lengthening of the posterior side of the pelvic floor. So that's one of the ones that I like to throw in.
Yeah, and I use that child's pose breathing for someone who can't get that posterior expansion, especially with their breath. And one of my favorite cues is, I don't know if you use this one, I tell them literally breathe into your butt cheeks. And if you do it well, you can actually
You do
feel the expansion through the...
I explained to them that what I want them to feel
we got
sometimes
the model, so.
is that as they are in there, child's pose,
Yep.
and they take that deep diaphragmatic breath, that they should feel the sits bones kind of move apart somewhat, and then as they exhale and air leaves, everything should recoil, and they would feel those sits bones kind of return back to a resting posture.
Yeah, so just trying to build that awareness of, hey, even though this is a relaxing position and breathing should help us relax, you're actually concentrically and eccentrically contracting your pelvic floor.
Yeah. And then that diaphragmatic breath, when done well, and that's something we work on in the clinic too, just to make sure that that too is being done well. Mm-hmm. It's going to help kind of like, at least in two categories, kind of down training or getting that nervous system to relax somewhat. So from a nervous system perspective, helping to reduce some of that muscle tension.
Oh, for sure.
And then directly on the muscle tissue, because a nice inhale, diaphragmatic inhale is going to get physical lengthening of the tissues. So it's kind of a two birds, one stone kind of exercise.
We're all about efficiency. Yes, exactly. You have to be efficient, especially when you got patients all day.
Yeah.
Well, actually, I think the camera's pointing down, but for you watching, most people know what a child's pose is, but I'll just show it. If you're in this tabletop or quadruped position, you kind of sit back onto your heels and then drop down here. And then from here, this is just a good position to think about just trying to breathe. And then obviously with certain cueing, you could help with that. Another one, if like I know, well now, this is before I even knew you existed, some people I would try to help with pelvic floor by like rolling up a towel, putting it in with the anatomical perineal region.
Yeah.
Thank you. And then just seeing if they could breathe and then just feel the difference in the towel while they're doing it.
Any of those proprioceptive cues are really helpful, again, because it's not a muscle that, we can see the action. Really, sometimes people they have a hard time feeling the action. So any of those proprioceptive cues that give them more feedback into the body is awesome.
And then through, I would imagine rehab progressions are just getting into higher level stabilization and then making sure they can still get that intra-abdominal pressure. Mm-hmm. Is there certain things you're looking for? Is it like they're breaking plane, they're going into that secondary breathing strategy? Is there any like obvious things that you look for when trying to progress rehab to be like, ooh, we're not ready just yet, let's peel it back?
Some of it's in the clinic, like progressing those postures, starting supine, sitting, standing, and then taking it into movement. Are we still seeing good breath mechanics? But then I also, since we only have so much time in session with each of our patients, it's also a lot based on how they're doing with certain aspects of a home program.
Yes. You telling me you give homework too?
A lot of homework.
Our patients are used to that. Hopefully they're used to it. Okay, good. I was like, I would love for you to be completely better in like 15, 20 minutes with me doing all the work, but you spend way more time away from me. So if you just do a couple things, it's only going to be more efficient.
Yeah. No, it's about using that session to like guide patients to doing, stuff at home that will help ultimately make them independent, symptom-free.
And resilient.
But yeah, so sometimes it's asking them to work with the homework that we've given, breathing homework, strengthening homework, and then seeing how their activities that they want to be doing, are you still experiencing symptoms with those activities, such as running. Like running is one of my favorite ones to work on.
Yeah.
And of course, like out the gate, I'm not going to have somebody go home and try and run if we've just started work, but it's getting them through like a little bit of an agility progression with their breathing exercises. Just maybe even a little bit of like double leg bouncing, then single leg bouncing, starting to take away some of your base of support.
Yeah.
Keeping that breath pattern going. And then if it's available, adding fun stuff like getting a little bounce on a trampoline. Okay, are we still maintaining like symptom-free movement, pain-free movement? And then, ultimately using that progression back to their highest level of what they want to be doing. Say it's running or lifting or whatnot.
And that's tough with all athletes. I'm sure it's the same thing for you, where if they're like a marathon runner, strongman, power lifter, you're already strong. But if that strength is on a poor foundation, it's either you're going to plateau in your performance or you're going to keep getting reoccurring injuries over and over again. So that's the tough part is, if you got a race in the next couple of weeks, okay, we'll get you to that. But afterwards, we really need to peel this back, build up that foundation again.
Yeah.
And then you can easily add layers on top of that. And you'd be shocked at how much stronger and how much better your performance is if you take a back seat for maybe a month, 2 months at the max, depending on the situation. And
I'm sure you won't be surprised, but I've had patients where, like, the basis of what we started working on was that deep diaphragmatic breath, good three-dimensional breath mechanics. And that alone, I've had patients kind of go for a run, work with that, and come back and tell me that running was easier and they ran without leakage. Now, that's not to say that's the cure-all for anybody running with leakage. But, sometimes it can be that breathing can be that impactful on treatment.
Yeah, and a lot of that feeds into, well, we're born with proper breathing mechanics, but obviously societal norms has us kind of more sucked in. And that's where whenever we're teaching breathing concepts, it's like, I'm not making you fat. I'm just teaching you how to stabilize.
And I'm sure we see this with male clients too, but I see, majority female clients. And so we get into that, a little bit societal tangent of the fact that we're always trying to like hold our stomach in and look as trim as possible because we want that aesthetic. And really, at the end of the day, we might be now over gripping through parts of our abdominals, which is one of the things we try to.
Which I'm guessing you can't over grip abdominals and not affect the pelvic floor because you're affecting your diaphragm. I mean, it's a symbiotic functioning relationship between all the muscles. And it's our center, which is why they call it the core. So if it works properly, then everything's good. But if not, then obviously things go south. That's where I tell everybody, save your 6-packs for the pool. I'm still looking for mine. But whenever we want higher performance, higher stability, then that's where we really need to maximize intra-abdominal pressure.
Yeah, because if we're just constantly gripping through the abdomen more for an aesthetic purpose, or because somebody told us that we have to grip the abdominals to maintain core stability, then we're losing function of the abdominals being able to expand and contract as they should be throughout our motion. Yeah,
and that's the big, well, maybe this is going into a side tangent with core function that eventually was going to happen if we kept talking to each other. But, core muscle, or when most people think core, they think abs, right?
It's not just the abs.
So ab contraction plays a role in core stability. Like if you breathe out all the way, you can feel that contraction. But also you just sacrifice your intra-abdominal pressure. So if you don't have that, if you have contraction without pressure, then you can only stabilize so much. It's learning how actually, if we eccentrically contract, especially with our breath, we get more fiber interlay. Actually, you're stronger that way. Plus you have the pressure. Then you add a contraction or a brace, and holy crap, I don't have back pain lifting anymore. You can tell I'm going on a little bit of a soapbox right now, but I'm sure you've had these same thoughts before when it comes to the pelvic floor specifically. So we went over, well, what the heck's a Kegel? Well, the biggest issue with Kegel is, well, are we even doing it right?
And most of the time, half of the time, at least according to the research, half the time we're not.
Well, as you were describing it, I was like, I don't even think I'm doing it right, but that's besides the point. I'm not a pelvic floor expert. And then the big thing is we went over when we should Kegel. Can you give a quick synopsis on when are those good times? And I'm sure it's sprinkled in like through your care.
Yeah.
Everybody's probably getting a taste of Kegel, or at least you're assessing how well they can volitionally contract. When would that be a big player in someone's kind of treatment process or care process?
In a care process, when I can tell that the pelvic floor isn't overactive and contributing to symptoms, like we're not experiencing significant trigger points within the pelvic floor, pain with pelvic exam, difficulty with initiating urination or bowel movements, or if there's a lot of straining, again, then I'm thinking that the pelvic floor might still be overactive.
Yep.
And so if we're just looking now for general strengthening and connection, then I include a Kegel. And I will include them in sets of, say, like 8 to 10, 8 to 12 for like 3 to 4 sets.
Mm-hmm.
There are some studies that show that that's kind of the sweet spot. We don't need to be doing like 500 a day.
Yeah, exactly.
As maybe some people have read.
Like if you're thinking you're Kegeling,
but
not that.
3 sets of 8 can be perfect, can be the sweet spot. And then sometimes it's, are we doing just an engagement, or am I having the person engage pelvic floor and hold and try to have a sense of holding that for a period of time? Because as we've talked about, with pelvic floor being a core muscle, it has more of a makeup of our type 1 slow twitch fibers. So it's a muscle group that we want to be firing kind of at low levels in the background, like most of the time.
Yeah.
And so if I'm just going to have you engage and release, well, that's great for a type 2 fast twitch muscle that we don't want to be engaged for longer.
If you got to
periods of
load
time.
and explode for a split second, that makes sense.
But pelvic floor, we want that on most of the day to help us maintain continence when we just stand up out of a chair or, pick something up off the ground. So we start to work on making sure that the patient's able to engage that for a little bit longer times, 15 seconds, 20 seconds. And again, not at high reps.
But just trying to build up that isometric kind of tolerance to it. Because I'm sure it's just like when I go over core stability with patients, I'm not like, hey, if you need to pick up a piece of paper off the ground, you don't have to brace and bend. Same thing with like pelvic floor. You don't have to like Kegel before you get up to try to avoid leakage.
Yeah, we shouldn't have to.
Which it's probably not your fix if that's what's going on anyways. Hopefully you guys are catching on.
Well, and sometimes we include, I'll have people include pelvic floor activation with a functional movement so that we're incorporating both the pelvic floor activation and then now functional patterns on top of it. So Kegel and bridge is one of probably my go-tos as we're building our progression. Kegel and single leg bridge, Kegel and lunge, Kegel and sit to stand sometimes.
Yeah, it depends on the person.
As we build those functional patterns too, because you want pelvic floor to fire, but we also have to make sure that it's firing in relation to the muscles around it. I'm
curious, just because we're talking about the Kegel specifically, have you, just because I'm curious as a clinician, what's the craziest thing you heard from a patient coming in like, hey, I've been doing 1,000 Kegels a day and I still haven't fixed my issue? Has that happened to you?
I get more of the fact that somebody will tell me that they've done them, doctor recommended them, and it's just not solving the problem. So
it's more like a process of,
like they've tried
I'm frustrated.
And now what? Because this alone isn't helping.
Well, it's just like anything. It's a good tool. Like as a McKenzie provider, people are used to like a press up or they heard of extension in line. But it doesn't mean everybody gets it. You have to have your assessment and kind of know where to plug and play. Yeah. So I was just curious if you had any crazy story there.
Not too many crazy stories there.
Oh, well, how about this? What percentage of individuals that say they've been doing Kegels were just doing them incorrectly?
I gotta say, I think
Is it over 50?
No, I think my clinical practice is like kind of dead on with the research, 50-50.
50-50, right on the dot?
Yeah, and then some of our time in session can be spent coordinating that engagement so that when they're working with their home program, they're engaging well or relaxing well, because you still also need to be able to relax the muscle or take it to its full muscle length to be able to, again, more for
and that's
bladder
more
function, but you have to be able to let the muscle lengthen.
That's more when not to Kegel.
That is not to Kegel.
Not to Kegel. When to Kegel, when not to Kegel, that is the question. I think we dived into a lot of concepts to answer that question. You know what, if you're ever curious on who could answer that question, a pelvic floor specialist can answer that, huh?
Pelvic floor specialist is the number one. Is the number one specialist to help you with that.
So if you've been following Instagram or TikToks of do your Kegels upside down now, if you're still grasping at those straws, just know that there's someone out there to help.
Thankfully, there are more and more of us each day, and
I mean it's been growing. I mean, you've been doing it for a while. I would think it's more
But it's a growing field of clinical practice, thankfully.
Yeah, I mean, it's kind of like the rehab chiro. It's not super common, it's growing, but now people are kind of realizing it exists and they're like, holy crap, I wish we found this sooner.
Yes.
That kind of thing.
Yes, most definitely.
I think we went over a lot there. One last time, who are you and where can people find you?
Dr. Nicole Lorenz, orthopedic and pelvic floor physical therapist here in Plymouth, Michigan.
And we've gone on a couple tangents now, so if anyone wants specific topics about the pelvic floor, maybe we should schedule like a live Q&A for one of these too. I feel like that'd be cool to set something up. Or if you think that's a dumb idea, let me know in the comments. But either way, we'll have Nicole on soon, and then there's another episode talking about the pelvic floor. So we're always learning and we're always teaching each other, especially from a professional standpoint. So if you want to see any other types of professionals on here, let me know so I can reach out to them, and then we'll just keep on getting smarter.
Thank you.
We'll see you.
All right.